and good afternoon. This is Pradeep Goel, and it is a pleasure to get on this session with all of you. We have a lot to cover today, lots of information to share with all of you. So without further ado, let's get started. I hope that every one of you and your family members and your loved ones are staying safe in this new era of pandemic and travel restrictions. I am broadcasting from our office in Kiev. I've been here for the last 4 months, although I made a short trip back home to the US for a couple of weeks, and brought my children and my family here with me so that we can reduce the amount of traveling and the time away from each other. So I'll be here in Kiev for the next several months and make sure that we stay very focused and keep our team very focused. With that said, I hope you're doing all of you are doing well, and your families and friends are doing well as well. Today, we have a lot of material to cover. We're going to focus on the big project that Solve.Care is working on, Global Telehealth Exchange. And there is an incredible amount of exciting progress, information, and strategy that has developed rather quickly. And I want to share that with the community. Also, before we get started, I want to say thank you to the incredibly supportive community that we have around the world. Many of you are engaged with us on a daily basis. You have great ideas and you continue to share them with us. And for that, I'm deeply grateful, and so is the team. And I also want to thank the Solve.Care team before we get started, because they are doing absolutely incredible work. And I will say that during this pandemic, if anything, our team has worked harder and more effectively than even before. Everybody is engaged, even though they are forced to be remote. We are an extensive user of remote teleworking capabilities, and everyone in the organization is working harder than before to make sure that we stay on track for our mission. So I'm very proud of them. I'm very grateful for the work they're doing. And I hope that you will recognize and encourage and thank the people as I do on a daily basis. Let's get started with what I want to share with you all. So we are going to cover an extensive update, starting with the presentation. And this will cover a lot of the questions and areas that people have asked me to address. So let's get into it. The agenda is quite extensive, but focus on Global Telehealth Exchange. So first, I will share with you the status and plan for the Global Telehealth Exchange. What is the physician interest and adoption that we are seeing around the world? How are we going to implement the credentialing and compliance strategy to ensure that we are compliant with applicable laws? And really, why are we launching GTHE in the face of everybody building a telehealth solution? And how is it different? I really need you to understand that because we need your support to promote GTHE around the world. And also, how GTHE has quickly evolved into a global healthcare payment system, which is a fantastic opportunity for the Solve token to become the de facto payment currency for healthcare around the world. And it is an unbelievable area for our growth, both in terms of technology and adoption and revenue, but also solve utilization. And then our plans for commercial availability and the phases in which we expect to launch. And I will try and make sure that we have some time for Q&A. And if we run out of time, then I will encourage you, all of you in advance, to get us your questions. And our very capable community managers will get those questions to me. So let's get started. First, I want to introduce to many of you who may have only heard of GTHE as to what exactly is Global Telehealth Exchange. So there is a lot of talk about telehealth right now. In the COVID-19 reality that we are all living in, traveling is difficult, constrained, and simply not an option in many cases. And physicians and patients are interacting more online than they're interacting in person for safety and for convenience. So why in the world where everybody's rushing to build a telehealth solution would Solve.Care be a relevant and valuable solution? And the answer is because we are, in many ways, fundamentally different. Many telehealth solutions that exist out there allow the patient and the doctor to interact in the context of a sponsored care model. An insurance company or a hospital system or a provider network can participate in a telehealth solution and invite their patients to interact with that physician. But it is not really about improving patient choice and access. What it does is gives you an alternative to in-person office visit. And what GTHE does is exactly what nobody else is doing, which is to focus on matching the right patient with the right doctor. And the vision is any patient can access every doctor, and every doctor can see any patient worldwide, as long as the rules of that relationship are met. So on the right-hand side, by simply downloading the Care Wallet, a patient can determine their need for healthcare, their urgency in they need the healthcare, the cost level that they're willing to bear, the accessibility requirements that they have, including language and other preferences, and to actually make a real-time payment to the physician all within their Care Wallet. And when that Care Wallet puts the patient's need on the exchange, on the Global Telehealth Exchange, which is a form of a care network, then we can match the patient's need to available physicians through a sophisticated matching algorithm. And we can also facilitate the match with appointments, with sessions, telesessions, with record exchange, with the referral management system, with payments, with care continuity and follow-ups, and a lot more. But the key element is this is an exchange, right? Many of you know crypto exchanges, you know stock exchanges, and there you're matching buyers and sellers. And here we are matching care seekers and care providers. But it's an exchange in the truest sense. You don't need to have a pre-existing relationship with a physician, or the physician does not really need to have a pre-existing panel relationship with you as a patient for that match to occur. The match is initiated by the patient in the Care Wallet, but on the left-hand side, the physician has a very robust Global Telehealth ID profile, which at the heart of it knows and can document and has a proven information about the doctor in terms of their qualifications, in terms of their credentials, and the licenses that they possess in terms of what patient category and jurisdiction they can provide care in. They can set the eligibility criteria for which patient they will see, and the visibility of how far away from their place of operation they are willing to see patients, and what their availability is. And they can also set their rates and receive real-time payments. But that Global Telehealth ID shown on the left-hand side matches through the GTHE with the patient seeking care. And that matches real time, which means that a parent in India can match with a doctor in Boston. And there is, as long as that is allowed in terms of a jurisdictional law and compliance, then that match will occur. The match isn't based on the fact that the doctor already knows this patient, or the patient is in the doctor's network, or the doctor has an insurance plan that this patient is already a member of. The match can occur on the basis of patient-paid model, or it can occur on the basis of other eligibility criteria set by the doctor. So this notion that we are matching buyers and sellers of healthcare is similar to how a true exchange operates when you have buyers and sellers of stock, or buyers and sellers of BTC. So we have modeled the concept after a true exchange, which means that the service providers, the seller of services on the left-hand side, sets the parameters in which they're willing to sell their services, similar to how you place sell orders on the exchange using limit orders or market orders or stop loss orders. You have the notion here of a physician establishing their criteria under which their services can be bought. And on the right-hand side, you have a patient who has their own criteria of how much they're willing to pay, how fast they need to see the doctor, what qualifications they are looking for, what level of language and preferences match they need for them to be matched with the doctor. So we are creating an exchange of tele services. And the objective then is to ensure that the match is intelligent and compliant. And the exchange offers the fundamental capability of instant appointments, real-time telesessions, safe record sharing, out of real-time referral management, real-time payments that occur in Solve tokens between wallets, the ability to do care continuity through how are you feeling today and other care cards, and a lot more to come. So this is what we are building. So this is very different than saying, listen, I have a telehealth product which a doctor community can offer to their patients, because we are essentially in that model serving existing relationships. And in GTHE, we are talking about creating new relationships that the doctor and patients do not have and cannot find. So you see the difference. We are fundamentally changing the way care is bought and sold, as opposed to simply facilitating a replacement for in-person visit with a televisit. Completely different paradigm. Having said that, the foundation of the GTHE is the GTHE ID. So this is really interesting and fundamentally different concept, because instead of having the physician hire a staff, front-end staff, back-end staff, to manage their appointments, their calendar, their office visits, their billing, their payments, their collections, their reminders, their care continuity, we decided to build a permanent blockchain node for each physician. And that node is an active node which has a lot of intelligence. And this node is always on, which means that anyone external, be it the insurance company, be it another doctor, be it another telehealth solution provider, can interact with this global telehealth ID and verify the physician credentials, verify the eligibility criteria, availability and timing, and rates and payments. So the doctor does not need to work as hard as they normally do, because the ID does most of the work. So the global telehealth ID is not some kind of a concept in the sense it's an address. It is a permanent address, and each doctor has their own ID that they own for life. But it's also an active node which can respond to an inquiring agency, administrator, employer, physician, hospital, insurance company, pharmacy. A lot of the inquiries the GTHE ID can handle on behalf of the doctor. It's an avatar. It's a digital avatar of the doctor, but it allows them to essentially divest themselves of the need to have staff and be online to be able to practice medicine. GTHE ID in many ways allows the doctor to be available and online 24/7 in terms of the transactional interface. It's also a personal payment gateway. Instead of having to share their bank information, to share their electronic fund transfer information or their PayPal address, which most doctors will not use anyway, but instead of being available to offering and sharing their payment, various different payment models, the GTHE ID simply accepts payments on behalf for the doctor in a fully auditable and secure manner. As long as the sender is sending Solve tokens to the GTHE ID, they are essentially replacing the need for ACH, EFT, PayPal, Venmo, whatever. And the doctor is always on, and the payment is fully auditable and fully secure. So we have essentially combined three very fundamental concepts that today the doctor has no other way to do except to have a bunch of staff, which is the permanent, identifiable, unique address that they can share with everybody who they interact with and everybody who needs to interact with the doctor. That address is active and able to respond to credentialing requests, eligibility requests, availability requests, payment, bills and payments. And it's a secure payment gateway, which also allows the doctor to receive at that address payments in the form of Solve tokens. On the other hand, GTHE ID represents a secure, encrypted, HIPAA-compliant transaction capability. It also represents completely automated administrative function capability, so I don't have to have, as a physician, 100 different interfaces with 100 different insurance companies. And I can transact with third parties using my own lighthouse. So that when I publish my GTHE ID, given that all GTHE IDs have the same method of interaction, anyone who knows how to interact with GTHE ID can now interact with me. And I don't have to buy another EMR or another payment system or another accounting system, and on and on and on. So we are really changing the way physicians can practice medicine. And the message here is, let's bring joy back into the practice of medicine. Let's remind everyone why the doctor became a doctor in the first place, to take care of patients, not to be a data entry clerk, not to be an EMR expert, not to be an administrative guru at billing and payments and insurance and eligibility and pre-authorization and referrals, but rather to be a doctor and let the GTHE ID offer a permanent, secure, reliable, evergreen interface that does most of the work that the doctor shouldn't have to do in the first place. So the goal is to make the physician hyper efficient, hyper effective, and actually enjoy the practice of medicine once again. So when we explain the value proposition of GTHE and GTHE ID to doctors, there is a tremendous interest from them because we are speaking to their pain points. We are addressing what they struggle with in terms of practice of medicine and what they really want to be able to do. Now, this is really important for you to understand. I've highlighted the word specialists. Our original thinking of GTHE was that this is going to be a more effective solution as an alternative to in-person visits. So we can do a consult through GTHE much more effectively than we could do in in-person office visit. And we were looking at the normal model of teleconsultation, particularly in the context of COVID-19 and the travel restrictions that exist for all of us. But what we have heard from the doctors is a completely different message. Our doctors, who are very engaged and worldwide, and I'll show you in a minute how broad an appeal we have, are saying to us, but I don't want GTHE to be just limited to a teleconsultation. I want GTHE to handle full care episode. I'm interested in not just scheduling a tele-session with a patient and charge $40 for that session and get paid immediately. I like it, but that's not what I want. What I really want is the ability to get a complete episode payment and complete capability to do care management for this episode start to finish. In other words, I want GTHE to handle appointment, follow-up, billing, payment, and reminders and referrals for the entire care episode, the entire care journey, as Solve.Care calls it. So this is a very significant shift in terms of who and how physicians want to use the Global Telehealth Exchange. We are seeing almost as much, if not slightly greater demand of Global Telehealth Exchange from specialty care providers who are interested in scheduling the surgeries and complex care episodes through GTHE, which means that we are quickly evolving into not just a teleconsultation platform, which is how we started the whole project, but rather a full care episode management platform where even things like surgeries and hip replacements and plastic surgery episodes and long-term care management is the demand we are seeing. We are seeing demands for GTHE from eye surgeons who want to be able to plan, schedule, collect payment for, and actually do eye surgery, and following that, do full care management through GTHE. We are hearing demands from plastic surgeons who normally rely upon on medical tourism for their primary source of revenue, who are highly sought after physicians where people fly in all over the world to get certain procedures from them. And these procedures can cost a few thousand to tens of thousands of dollars. And they want to manage that entire process through GTHE, as opposed to just the initial consult for a few $100s. So this has exploded in its scope, and I'll show you what that means in a moment. First, when we launched GTHE, what we found is that the interest level is not really localized. We have physicians with global telehealth IDs in Canada, in US, in Mexico, in Spain, in Ukraine, in India, in Bangladesh, in Philippines. And that's a snapshot of where we are. And each day we are seeing physicians across the world say, this is what I want. Now, each physician has their own idea of how broad a vision they want to cast in terms of which type of patients they want to see. We have a physician that is saying, look, I want to see patients around the world. I have no limitations on where I will, which type of patients I want to see, because I'm a world-renowned surgeon and I want to be able to accept patients around the world. And in fact, I would rather practice medicine globally with cash customers than to practice medicine only locally with insured customers, where my rates are much lower. And I'm a top physician and I want this flexibility to accept patients worldwide. That model is a completely different model than a patient and a physician that says, you know what, I only want to see patients who I can do a follow-up in person. So limit my visibility to 100 kilometers of where I practice. That's also their choice. But you have physicians on one side who are saying, I want my visibility, my global telehealth ID to be visible worldwide. And then you have another physician saying, I want my global telehealth ID to be visible to patients only in the 100-kilometer radius around me. And the answer to both is yes. You set your visibility parameter. You define how bright is a GTHE ID set to be so that it can be seen as far or as broadly as you want it to be seen. Which means that the matching algorithm will match them to patients that meet that eligibility criteria. There are physicians that only want to practice online 4 days a week, and they don't want to practice 3 days a week. And there are physicians who want to only practice on the weekend and not on the weekdays, but they are working in a research organization and they want to focus on their research during the week and want to offer care only on the weekend. And there are physicians who want to offer humanitarian care only, who are only interested in because they are no longer actively practicing medicine, but they have an active license and they want to offer care to those in need. The point here is that every doctor should be able to practice medicine the way they want, with whom they want, and for however many days and weeks and hours they want, and have that the GTHE enable and empower them to do so. My prediction is that over the next few months to a couple of years, we will see every country on the planet to have physicians with global telehealth ID. How fast we'll get there, I don't know, but I definitely know this, that we will have global telehealth ID enabled physicians around the world in the very, very near future. Now, what does this ultimately mean? Why are we getting the kind of interest we are getting? So from a physician perspective, what's really interesting is that your global telehealth ID gives you global patient access. You can broadcast your GTHE ID worldwide, or you can restrict it to a geographic region or even to your immediate region where you live and work. No matter how broad you broadcast your GTHE ID, depending upon the criteria you set, all appointments are automatic. There is nothing for the physician to do. The appointments are requested by the Care Wallet. GTHE Care Network matches it to the physician's availability, requires that the patient make a full payment for the appointment to be confirmed. And once a payment is made in Solve tokens, immediately confirms the appointment, and the doctor can be out having dinner with his family when all this happens. And there is no human involvement. So appointments are 100% automated. There is no need for a manual billing process. The doctor sets the rates based on the type of service and appointment they want, and those rates are automatically charged and payments are collected and money is deposited before the appointment happens, and we handle all the complexity should the appointment be canceled by the patient or by the doctor, or there might be other issues that are in nobody's control, and automatically the payments are reversed or collected, and we do everything for them through the GTHE ID. There is absolutely no cost to the physician in collecting these payments. They're not paying additional fees for these payments to be collected worldwide. They can accept the same payment model from a patient that lives 100 kilometers away or 1 kilometer away, or from a patient that they will never see in person and lives on the other side of the planet. There is complete control over all the criteria of practicing medicine: the time of the day, the hour of the day, the day of the week, the week of the month when you want to be available, how far out can your GTHE ID be seen, what are the criteria, cash only or insured only or both. And most importantly, our model is based on global utilization. So we're not charging doctors some crazy fixed session fee. We are saying to the doctor, our revenue, Solve.Care GTHE revenue, is piece of the Solve token that you're going to get paid. So if you get paid 10,000 Solve tokens, we'll take some of those Solve tokens as payment for you to be on GTHE ID, but it's part of your revenue. You're not going to be forced into paying us more money than you're going to charge from the patient. Whatever you charge the patient, we'll take a piece of it. So the doctor has full control over their rates and their prices in the market and who they want to charge what. And we take a percentage of that, as opposed to forcing them down the path of $40 per session, whether you charge $4 or $400. I don't care, doc, you pay me $40. That's the model of every other telehealth solution. We're not going to do that because we're on the doctor's side. We're not here to force them into an untenable financial situation. So we very much think about how the doctor wants to practice medicine and how we can be a true partner in that model. So this is a very, very different way of practicing medicine than almost any solution. But further, when you combine the matching capability of an exchange model with the global payment capability of Solve token, you begin to create a model of care delivery that simply doesn't exist. And that's what we want. Because look, we got to make healthcare more accessible. We got to make healthcare more effective, and we got to make healthcare more affordable. And we're not going to do that if we keep siloing doctors into smaller and smaller networks, if we keep creating more and more boundaries around who can see whom and when and why, and keep creating more and more bureaucracy. And believe me, I've been in healthcare all my life. All I've done is administer healthcare. And frankly, all I've done is build systems that are epitome of this bureaucracy. And we need to make sure GTHE works exactly the opposite way, okay? On the patient side, the attraction is that you have much bigger access to care. And this is very important to understand. There are two use cases here that I want you to take away. The first is that, the avatar of a poor parent, a single parent, if you will, who is busy with the life and has very limited access to local care, that simply needs to make sure that the kids do get the care they need and they're not limited by the geographic limitations of care availability. So that's one kind of access. There's another kind of access where the patient wants better choice. I don't want to access care locally because I want the best surgeon to treat my parent who might have a glaucoma and needs an eye surgery. And I want to find the very best surgeon in the world and make sure that he or she is taking care of my mother. And in that case, I'm willing to pay for that kind of a top tier service. Both these patients are effective users of GTHE. It's not one or the other, it's both. Yes, I could be driven by need and lack of availability, or I could be driven by choice and willingness to pay for that greater set of options. One patient, the first scenario, the patient might pay $5 or $50. In the second scenario, the patient might pay $50,000. But the point is, it's driven by patient choice. It's driven by patient access. It's driven by patient's decision, not by some predetermined model of care that somebody has imposed upon them. That freedom is what we are bringing to market. All right. So remember that we have a peer-to-peer model in our system where different nodes can talk to each other. So a doctor can easily connect their node to a physician, a specialty care physician, and either give or receive referrals and do care continuity with that physician. And the patient can create care circle with their family members who might help them subsidize the cost of care or keep track of their prescriptions. That model still is obviously there. But what the exchange does is allows for this matching and for real-time transactions to happen with minimal effort on both sides. And this is the value proposition that's getting our doctors and our patients really excited. So now I want to show you an interesting model. This was our original model, how we were imagining and projecting utilization of a simple teleconsultation to replace in-person visit model. So we created 3 columns: a single doctor, a 100 physician small clinic or a mid-sized clinic, and a 1,000 physician network. And we modeled it as to how that would look in terms of the Solve utility. So assuming a $100 visit, of course, that's going to vary country to country, but we have to start with a baseline. Assuming a $100 visit and assuming 100 sessions per physician per week, which is actually less than average right now, we would see a utility of about $66 And this is the utility that we will see on Solve token for a single physician, for 100 physicians or 1,000 physicians. It's about 66 million tokens, right? This will be your weekly utilization. And this is the model that most telehealth solutions are designed to do. And we also started with this same assumption that we will replace in-person primary care visits with teleconsultation sessions, okay? While this is very compelling, and this is not this is a very exciting use case, this is what happens when you actually go from teleconsultation to telehealth episode management. Let me go to that. Now you have a scenario, this is the second type of the patient, where the physician is actually a specialty care provider or a top surgeon or a plastic surgeon in Seoul who is commanding a high dollar but a very high quality service that the patient elects to get rather than simply replacing the in-person visit. An average procedure for a specialty care provider, let's say for eye surgery or for plastic surgery, is certainly not $100. It's going to be 100 to 150 times bigger. So using $5,000 as a procedural cost and only projecting 10 procedures per week and using the GTHE to coordinate that care episode, we would see 5x more adoption in terms of Solve utility for the same 1,000 provider network. But the impact is much, much bigger because you now have, for this physician, a much, much better patient panel than they would have otherwise, because the current telehealth solutions will say to them, okay, you can invite your current patients to join, and it doesn't change the revenue model. It simply says, now you have an alternative way to see your patients. Our model with Global Telehealth Exchange is to say to the same doctor, listen, if you join the GTHE, you will actually have more patients, and you have the choice of patients, and you have a much better utilization and a much more even workflow and work-life balance. So what we are driving to is to enabling both sides of the care model. The fundamental care model where we are replacing this model, going back to where we are replacing in-person visit with a telesession, which is obviously going to be in high demand during coronavirus. But what happens post-coronavirus? So what happens if we actually bring in the elective care, where the patient choice and the patient need for top care brings in a completely different model? And these two work together. They're not mutually exclusive. Scenario A on the previous slide and scenario B on this slide simply illustrates a point that there are very different care episodes, and both are served on the same GTHE through the same model, but the utilization of the token is completely different and very exciting. And this was the big takeaway in talking to our physician community. We certainly were sure of the first model that I've shown you, and we were projecting that as a primary driver. But what we have heard from the physician community is, I want the second model as well, because that really interests me in terms of achieving a better work-life balance and a better effective utility of my time. And it also optimizes my revenue, and it gives me a chance to practice medicine the way I want to, with whom I want to. So it's both. And that's really been a huge aha moment for us. Dr. Hannekam, our Chief Medical Officer, has been working with physicians one-on-one and making sure that we hear them loud and clear. In our ambassador program, which I'll talk about in a few minutes, has been around the idea of getting physicians' involvement, both in utility and adoption, but also in the design of the product. And what we heard was quite startling. And as a result, we have made a lot of changes or enhancements to our model of the GTHE launch, which I'll talk about in a minute. But you can see the difference. This is traditional telehealth, teleconsultation model, and this is specialty care, concierge care, patient choice model. Now, to achieve the patient-provider match, which is the primary purpose of Global Telehealth Exchange, in that it's a true exchange, we have created a three-tier view of the physician. The first view is we need to verify that the physician is a licensed physician and where they can practice medicine and where they can't. We have also started to build out a global telehealth peer review model where physicians can review other physicians, both in terms of their credentials and in terms of their quality and outcomes. And then in certain cases, we can even go in and verify the physician's credentials all the way to the source of their education. And the idea is that we can show the level of verification that we have conducted about the doctor to the patient. So if a patient is looking for a certain qualification, they can get that through the licenses. But if they're looking for a certain rating system, they can filter further on the Global Telehealth peer review rating. And if they want us to, if they want to only work with physicians with whom we have done a much more detailed back-end verification, then they can look to the tier 3 verification. Every physician does not need every single level. Everybody needs the inner circle, the orange circle. The outer circles are at their choice. But this allows our patients worldwide to define the criteria of the match. And this gives the patients the certainty that somebody has done enough due diligence to ensure that they are dealing with a certified physician on the other side. So this credentialing model is very interesting in the sense that there is no global credentialing system today. We do not know of any entity that does any kind of a credentialing system and license verification and peer review for physicians worldwide. Doesn't exist anywhere. And it now under Global Telehealth Exchange, we're the first to do that. Those of you who are in healthcare administration may recognize the importance of that. That in itself is a massively complex but massively valuable undertaking. And we are building out this credentialing team, license verification team, and processes in partnership with a variety of third-party vendors who can do some or part of this verification. But ultimately, Solve.Care has taken on the mission to build this global registry. And this global registry of physicians, which results in global telehealth IDs, is an incredibly powerful system which allows us to enforce both the quality and to automate the operations of the doctor and the patient. So this is a bold undertaking, and it is requiring significant investment from us. And we are making this with our eyes open, that not only does this launch GTHE around the world, it also changes the way insurance companies and government agencies and provider networks and hospital systems and even medical universities can automate and improve the way they conduct their due diligence. So in itself, the license verification and credentialing is going to be a valuable use case for Solve and Solve Token. Because if the physician is on Global Telehealth ID, they already have their GTHE ID, to access these credentials by a non-patient can result in a Solve token being utilized to provide that access, both in terms of control and cost. So this is a very interesting sub-use case, which we don't really project in our utilization model today, because we are only focused on utilization of Solve token between patient and doctor. But understand that there is a completely separate and independent use case around credentials and license verification and a global provider registry and Solve token being utilized from a business to business access for that information. So I want you to think about this. This is a incredibly powerful but secondary use case, because the primary use case is what it is, which is to make sure that patients can find and pay the doctor that they need to see right now. Now, one of the big things that I want you to understand is that GTHE is not just an exchange, it's also a global payment system. What we are really doing here is we are providing a mechanism for doctors to receive real-time payments from patients worldwide instantaneously with no overhead. So the Solve token payments that patients can make to a doctor in the context of primary care, specialty care, procedural care, even in-facility care, all that is done between GTHE and the Care Wallet, which means there is no billing, there's no collection, there is no bureaucracy from a doctor's perspective. And from a patient perspective, it's easy, it's real time, and it's transparent. So this is a very important core capability. And we plan to allow third-party telehealth solution providers to piggyback on GTHE as a payment system. it is our view that just because somebody has a telehealth solution that they might have bought or rented from some existing vendor relationship they have, does not mean that they can benefit from Solve token as the underlying payment currency. So we are opening up the GTHE ID as a payment gateway using Solve token to other telehealth providers. So two things, the provider registry and the payment gateway capability are going to be made available to third-party telehealth providers so they can build their telehealth solution to whichever audience or doctors they're building it for, but they can leverage Solve token as a payment currency, and they can leverage GTHE ID as the administrative interface through which they can exchange provider credentials and licenses and so on. And those two factors allow us to essentially become an exchange of telehealth solutions. So that's the vision and that's the plan behind it. Step by step, we want to move towards the notion that Solve token as a token should be not just limited to GTHE for payments. It should be tied to GTHE ID, which can then accept payments from patients who may not even have booked the appointment through the Care Wallet. And now the implications are that we are essentially creating a global healthcare payment currency. And that's really what we want to ultimately do anyway. And GTHE moves us down that path much, much quicker. The next thing I want to talk to you about is where are we focused on? So our highest physician adoption is in the United States. And there we know that the cost per healthcare per patient per year is the second highest in the world. We are only behind Switzerland, or even in fact higher than Switzerland now, according to this chart. And the second area where we're getting a lot of interest in adoption from providers is from India, where the cost per visit is lower, but the number of patients is an order of magnitude bigger. So if you look at the number of visits, United States had about 926 million visits, and India had 4.4 billion visits. The cost of per healthcare is $10,000 versus 63. But remember that when you talk about patient choice, the number 63 means nothing, because patients who want better care choices will pay for the doctor rates, not the per capita rate. So if we have a massive visit rate of 4 billion visits a year, and you have a patient choice model where the patient pays for the quality of care they're seeking, then the numbers are staggering. But those are the two areas where we see the greatest adoption right now. And they both happen to be English-speaking countries, which makes our life a lot easier. But we are also getting interest from other parts of the world where medical tourism is a big deal, where there is a desire to offer second opinion. There's a lot of interest in using Global Telehealth Exchange as a vehicle for referrals and second opinions. So we are going to see as many different ways that the physician wants to deploy their Global Telehealth ID as there are physicians. They're going to configure the GTHE ID to behave differently based on where they live and where they work and what specialty they are in. But the bottom line is the same Global Telehealth ID in the USA for physicians with a very different set of criteria and eligibility, and the same Global Telehealth ID configured differently for physicians in India. Same Global Telehealth Exchange, same Solve token, same Care Wallet, just a completely different model of delivering and practicing medicine. And underlying all of this, of course, is Solve token. So one of the big things that we understood as we started to launch the Global Telehealth Exchange is that we started to realize we need to bring more and more currency pairs with Solve token so that we can allow the patient to see the prices both in Solve tokens and their native currency in the Care Wallet, and the doctor to be able to set their prices in the native currency and Solve tokens on their side. And when the payment is made, we are actually facilitating that payment in the most efficient way possible. So we're very pleased to say that we are one of the few tokens that have a USD pair on Bittrex. We of course have USDT pair. We also have Vietnamese dong pair. We have Australian dollar pair, Euro pair. And my team is very focused on expanding fiat pairs for Solve token so that we can allow a more transparent pricing for the patient and the doctor. Now, you can always price things in USD and Solve, that's given worldwide, you can do that. But the more pairs we have, the more we can demonstrate the pricing of that pair in the care wallet, the easier it is for a Vietnamese parent to see the prices in local currency because we draw that price against that pair. And if that price is something they can actually act upon. So having more and more fiat pairs is good, and we're going to stay very focused on that. And the second part of it is that for those of us who are somewhat familiar with crypto, the access to Solve token for the crypto community, we are continuously expanding that. But the key element here is very simple, that a parent who does not know anything about crypto, does not know anything about BTC, Ether, Solve token, can easily use the Care wallet, make an appointment, pay for it using Solve token, and the process is made incredibly simple for them. And that's really the point here, that they understand the price and they can execute that price. And they don't have to deal with hidden fees, hidden conversion costs, and all the rest of it that goes in dealing with crypto. We're not trying to make every patient on the planet a crypto expert. We're trying to make sure that they get the care they want and the crypto makes it happen, rather than it being something that they have to learn and understand. The last thing I want to cover is the ambassador program. So when we launched the ambassador program, we thought that we will get insurance brokers, care coordinators, we might get office administrators as the ambassadors. But we are actually getting physicians signing up for our ambassador program. What we are hearing from physicians is, not only do I want to use this GTHE model of care, I want to bring my friends and my coworkers and my network providers to come in and join Global Telehealth Exchange. So almost all our ambassadors are actually physicians. When we recently did an ambassador program roundtable, we had 900 plus registrations, most of them physicians. Our ambassadors are physicians who are involved in the design of the Global Telehealth Exchange. They are actively telling us things that they want. And through them, we have learned the idea that an in-person visit replacement model, while good, is nothing compared to care episode management model, which is where we have pivoted our attention to as an additional use case. And we are so excited about the physician feedback that we have created and will expand our dedicated provider relations team, which has one purpose and one purpose only: to support our ambassadors and our physicians in using, adopting, and promoting Global Telehealth Exchange around the world. And our focus is on both individuals and groups of physicians who work together in one capacity or the other. So the ambassador program is off to a very good start. Dr. Hanakam is, of course, as a chief medical officer, leading this dialogue, but we are expanding in a manner that makes us one of the few physician-centric global telehealth exchanges. In fact, the only one where the physicians actually have a voice in how the exchange is configured and how the exchange operates. Further, the physician community is now more involved in testing the Global Telehealth Exchange product, and they are looking at it as a preview of it. And I believe later next week, we have another session with our ambassador community and physician community to say that this is the almost final version of the Global Telehealth Exchange. What do you see as the necessary enhancements for the next release? So we're getting a lot of good feedback, and I think that this request that we are hearing about a controlled launch for the ambassador physicians first is a great idea, and we will follow through on that. The message being, let me as an ambassador / practicing physician use GTHE and really help you refine it before we launch it worldwide. So we are engaging our ambassador physicians into improving the product, which is a great advantage. There's nothing better than a physician that actually practices medicine every day using GTHE to tell us what's convenient and what might need improvements. So having said all that, this is the current status. So our original launch plan was on August 1 to launch a standard telehealth service with basically a replacement for in-person visit with a provider registry, appointments, and telehealth sessions and payments. This is our original scope. The physician feedback has been, yes, but that's only for the simple use case. What I want is the ability to create care groups around clinical need and around care continuity. I want total episode payment through the GTHE, which means that if the total episode of care will cost $5,000, I want to be able to manage that entire payment model through GTHE, not just the first $40 consultation. I want the ability for you to be able to export data to my EMR if need be, although I plan to use GTHE primarily as my EMR. And I want the specialty care model, not just the primary care model. And I want full care continuity platform. These are the feedback we got from our doctors that this is something that we want from Solve.Care in the first release. So we have, as a result, pivoted back to saying, okay, we hear you loud and clear, and we are going to make an adjustment to our release date so we can build in some, if not all of your feedback into the initial launch. In the meanwhile, we want all of you to be engaged as physicians in testing and verifying that the GTHE is working to your satisfaction. So the new launch date is, in our opinion, at this point in time, a Q4 2020 launch, which means that somewhere between October and December, we will launch a much more expanded Global Telehealth Exchange with the concept that it covers primary care and specialty care, not just care continuity, but care concierge model. And it is something that the physicians can use to do total payment model, meaning the payment model that represents this scenario rather than just this scenario. And to achieve this scenario utility where 1,000 physicians on the concierge care model would consume over 300 million tokens versus 1,000 physicians would consume about 60 million tokens. So this is very attractive for everyone. But more importantly, this is what the physicians want. So this is our new plan based on that feedback. And the summary of this is that the scope of Global Telehealth Exchange has expanded. It has expanded to a much larger opportunity. It has certainly become a very attractive global payment system using Solve. And we get asked this question all the time. What if I don't want to use Solve? And our answer is that's not an option. The only way you can access the Global Telehealth Exchange and this entire capability is if you accept payments in Solve tokens. There is no other option, but there's also a huge value to you as a physician because the payments are real time. There is no bureaucracy or overhead or friction involved, and you do not have the risk of Solve token price variability, which we have handled ourselves on the GTHE backend. So all of that means that the real objective here is to prove GTHE as a global use case for Solve.Care networks and Solve token, and open up the GTHE ID for payments from non-Solve.Care care wallet and GTHE. So in other words, really position Solve as a global payment currency between doctor and patient. So there is a tremendous amount of excitement and feedback from our physician community, and the concierge care networks are clearly a strong demand from them. And we are finding that the physician community, especially the specialty care community, is saying, launching a simple telehealth solution is great, but you got to give me a platform that gives me concierge care network model. And so we are responding to that. So the scope of GTHE is expanded from primary care to specialty care and concierge care, all three. And that's the picture that we are working very hard on. And the team is really rounding up enough physician feedback to ensure that we release the product that they're all looking for. With that, I'm going to move into the Q&A, and the team just handed me a lot of questions. So the first question is from Freedom Chief. Will GTHE be available in Europe, and how many languages is it available? The initial launch of GTHE is English. The physician can practice medicine in any language they want. There is no restrictions on that. Their sessions, their records, their interaction with the patient can be in any language. But the GTHE product is in English. And we will enhance it with other languages, starting with Spanish as being the next target, and then moving into other languages in 2021. But we are really focused on GTHE product to be in English, but we're not limiting you as a physician to speak English. You can conduct your telehealth sessions with your patients in Spanish or Chinese, but when it comes to using the GTHE wallet, you need to to do so in English today. Will it be available in Europe? Absolutely. I want to actually talk a little bit about this really advanced matching and compliance algorithm. The notion here, I want you to understand this. The notion here is that as a patient, I want maximum choice. I want to be able to choose the doctor I want no matter where they live and work. And I'll give you an example, a personal example, to explain the motivation behind patient choice. Let's say that I want a second opinion for my son. I want to, in my mind, this question exists. Okay, he's being seen by the top neurologist and child psychologist here in Florida. But how would he be taken care of if he was living in Sweden? If we were living in there, would the care model be different? Would I know something more about how I can take care of him if I was seeing a Swedish child psychologist? So my question is, why can't I do that? Why can't I make an appointment with a Swedish child psychologist who I happen to that GTHE can connect me with, and that psychologist is proven to be a real practicing clinically certified psychologist? And why can't I consult for Adrian with this psychologist and pay out of pocket? The answer is at GTHE, I should be able to, and I can. Now, let's flip over to the other side. I'm a psychologist in Sweden, and I get a request from Pradeep for an appointment for his son. My first question is going to be, well, I'm not authorized to practice medicine in the United States where this guy lives and his son lives. But if he really wants to talk to me, and as long as he understands and acknowledges that I'm a practicing clinician or psychologist in Sweden, and I'm not authorized to practice medicine in US, but I'm willing to provide you the care you want, as long as you acknowledge that I'm only authorized to practice medicine in Sweden. And if the law does not prohibit me from doing that, then there is a match. So the matching algorithm in Global Telehealth Exchange is driven first by patient choice, and second by physician's willingness or visibility perimeter, as we call it, and third by verifying that no law actively prohibits such a match. So this is an exchange, and willing buyers and willing sellers should be able to connect with each other as long as they don't break the law. And that is the fundamentals on which GTHE is being built, which means, back to your question, is it available in Europe? Yes. But the physicians determine the perimeter of their GTHE ID. How broadly do they want to broadcast the GTHE ID is the only question, and every doctor will determine the visibility perimeter of their GTHE ID. But fundamentally, every country, doctors in every country and patients in every country on the planet can access GTHE through the wallet, Care Wallet, and the web wallet. The second question is from Kevin. What medical data will be stored and where will it be stored? So fundamentally, we have built a off-chain medical record management capability. On the chain, we do not store medical data. We do not store protected health information. But off-chain, linked to the events on the chain, we store the necessary information, but the information is only stored either on the doctor's node or on the patient's node. There is no centralized storage, but it is a peer-to-peer storage model, very advanced architecture that we have spent years building, which essentially says, I as a patient can deliver records securely to the provider, and the data is encrypted and stored on the patient and the provider node, but nowhere else. So only the patient wallet and the provider wallet can see it. And furthermore, I as a patient have the absolute key to access or deactivate access to my records now or in the future. This is not a share and forget, but rather share and control and audit model, which is a unique capability of Solve.Care platform. So the answer in short is the data is stored in a secure encrypted vault on the appropriate node of each of the wallet, the sender wallet or the receiving wallet, or both. The next question is, one of the benefits of blockchain is that it can provide individuals with sovereignty over their personal data and facilitate permission-only access. If patients are to provide doctors with useful personal health information, then they may need to authorize access to data held within possibly multiple EHR systems. Curious to learn how Solve.Care will help individuals address this interoperability challenge. That's a really good question. It's a very nuanced question. So my personal belief has always been that I, as a parent, as a patient, must have control over my information. And just because I share that information with somebody doesn't mean that I have lost control over my information. So inside the Solve.Care platform, information that is shared between wallets can be controlled by the sender. Our core philosophy is data residency does not equal data ownership. Data ownership is a concept of who the data belongs to rather than where the data is sitting. And that ownership should not be relinquished just because you share the data with another node. So in our very sophisticated node-to-node control pairing model, we control the node A, which we call the EA, controls what EB can see and how long they can see it, even if there's a copy of your data on the EB node. Very advanced way to control information in perpetuity. But if the data is exported from the Solve.Care platform, there is little that we can do other than to ensure that the data is encrypted, and the receiving party outside of Solve.Care platform will need to request the key to decrypt it. So because everything on the Solve.Care platform is encrypted, even if an unauthorized sharing takes place, there is no way for the key to be automatically transferred. And therefore, the receiving party would still need to accept a Solve token, a Solve.Care access key issued by the data owner for the data to be decrypted. Having said that, the notion here is that a chain of custody can always be traced back to the patient, and chain of control can also be always traced back to the patient or the data owner. Then the third question is, in the GTHE FAQ, it talks about payment to providers and how tokens can be redeemed for fiat. Can you say a little bit more about how the USD value of these tokens is fixed? Sure. This is a very good question. So the way we have designed it, and I will do another session in the next probably 30 days or less, where I'll explain in great detail how we have built the underpinnings of Global Telehealth Exchange, but rather the core capability of the mainnet where we are managing the Solve token pricing model. But let me explain it to you in a very summary fashion. When a provider sets their price for a service, that price is set in two ways or in two currencies: the fiat pair, in which the doctor wants to practice medicine, fiat currency, and the equivalent Solve price. When the patient sees the price of their physician visit in their wallet, they see it in the context of Solve token first, and then it gets mapped to their local fiat pair. Okay? So if you think about it, if I'm practicing medicine in the United States and I want my visits to be paid in dollars, obviously, then I would say my primary initial consult is $100. So I'm going to set my price at 100 USD as a physician. And that translates into the real-time Solve token price in the patient's wallet, saying, this is how many Solve tokens you need at this moment in time to book Pradeep as an appointment with him. But if you happen to be a patient in Vietnam, it will also show you the price of the 100 Solve tokens in Vietnamese dong. So you on the buying side have a local Solve currency pair versus on the sell side, you have a seller's currency pair, and that match happens in GTHE. Now, when I make the payment in my patient wallet, I buy X number of Solve tokens using my VND pair, and that's facilitated through the wallet itself. And when I make that payment to the physician, at that point in time, Solve.Care handles the conversion of VND to Solve to USD. And we do that behind the scenes, and we lock in that price and we hedge against any variation. So the doctor is no longer dealing with the price of the Solve token going up and down. We are doing the appropriate transactions in the back end to ensure that that token is redeemed for the price at which it was deposited. And that hedging happens as part of this GTHE operation. And it's totally transparent to the doctor. There is nothing for them to do. There's nothing for the patient to do. And we are managing that variability. And it is very sophisticated. And I think it's something that when we announce it to you all, how we have done it, you will all, I think, very much enjoy it. But that's the way it works. The patient sees the token price of the visit and sees the buying cost of that token in their local currency, should they need to buy them. And the provider sees the equivalent token price on their side, and what is the equivalent redemption value, which is equal to the price of their service minus Solve.Care's revenue share. The next question is, how does Solve integrate with EHR? It's reliant upon patient requesting records from these previous physicians and uploading them, or not uploading but serving the documents when requested. And how would said out-of-network doctors access the data? Would they have to install the platform themselves? So first, nobody has to install a platform. Both the primary care physician and the specialty care physician, meaning referred physician and the referring physician, both have the care wallet, the web wallet version of the care wallet for the provider. So there's nothing for them to install rather than to create their GTHE ID and publish their visibility parameter and either turn on or off their ability to willingness to accept referrals. So in the context of record sharing between physicians, because these are two nodes on the network, as long as they have the sharing permission from the patient, those records can be shared wallet to wallet. There's nothing for them to do. The question now is, how does the patient get hold of their EHR or the electronic medical records, which are sitting in 25 different hospitals, systems? And I'll give you my personal example. A few years ago, I was quite ill, probably more stress-related illness, but it was quite severe. So I ended up going to Mayo Clinic for 2 weeks. Didn't quite work out well, weren't able to diagnose me. Then I went to Johns Hopkins University, and I spent several bit of time there. And then I finally ended up at Cleveland Clinic. Now it's ironic, these are the top 3 healthcare research institutions in the world, and certainly in the United States. And all those 3 systems, large care systems, had their own very, very complicated and fancy EMRs, except none of them talk to each other. So I have 3 different logins. I have one for Mayo, one for Hopkins, and one for Cleveland Clinic. And I literally am the only person who can download all these records and combine them, because I tried to get those systems to share data with each other, and between bureaucracy and technology and lack of willingness and lack of need, there's no such collaboration. So the answer here is the following. When it comes to using Care Wallet to make appointments and send records, it's the patient's responsibility to send the necessary information to their physician. But what happens when they do upload the information through the Care Wallet is that from that point on, they become the interoperability hub, and their vault allows them to maintain and control who sees that information in perpetuity and for how long, and it's as easy as swiping a care card in your wallet. Now, in the next versions of Global Telehealth Exchange, it would make sense for us to allow for direct interfaces to the top 10, 20 EMR systems in terms of technology, right? Epic, Cerner, McKesson, Athena, whatever you want to integrate with. But the issue isn't that. The issue is there needs to be patient access to the records to begin with. No matter how much we facilitate the highway, ultimately the patient needs to have the ability to access their EMR in the system from a credentialing and from an access point of view. So we will allow primary EMR integration for facilitating the transaction, but ultimately it's going to depend upon whether the store, the EMR in the backend, is willing to give up the information that the patient needs. And that, I think, is more of a interaction between patient and the record holder. And that's what we are trying to simplify. So the answer in short is the following. The patient has to load the data through the Care Wallet today. We will facilitate more easier data loading through EMR interfaces. But in the end, it's ultimately the patient's responsibility to gather their information, which today is scattered across 100 different EMRs. Next question we have is, how does Solve.Care plan to onboard other telehealth vendors without presenting itself as a competitor? Is it still part of the strategy? I have touched upon this during this session, and I will summarize it. So the notion is that telehealth providers operate inside a defined care network. They define who the provider is and which provider can talk to which patient, and they typically are a replacement for in-person visit, but they're not an administrative tool. Telehealth solutions, by and large, are not administering healthcare. They are simply facilitating a teleconsult session to replace an in-person session. We are designing Global Telehealth ID as a completely automated administrative avatar of the physician that is evergreen, ever present, fully controlled, and fully secure. So it's a completely different model. And it makes sense to allow the Global Telehealth ID to be accessible from other telehealth solution environments, which means that it promotes Solve token as a payment currency because GTHE ID will only accept payments in Solve token. It allows GTHE ID to be used as a digital blockchain avatar of the physician in terms of serving up content and serving up availability and serving up rates and credentials. So GTHE ID becomes a natural integration point for third-party solution providers. And last but not the least, just because we can do a video chat session through GTHE does not make us a competitor for telehealth solution providers. Their business model is different. So the commonality between us and them is that both use video chat to allow patient to see the doctor. But that's where the commonality ends. The rest of it is a completely different paradigm of care relationship. We are allowing for matching between doctors and patients. They're allowing for existing relationships to be done online. So I don't see us as a competitor at this stage. And I think that the value we bring to telehealth solution providers far exceeds any downside of being perceived as a competitor. And we see ourselves as a facilitator of administrative and payment transactions for telehealth solution providers that don't have that capability. So that's where we see the value proposition. And when I say that our goal is to make Solve token the global healthcare payment currency, we're going to achieve that by being a value add, not just to the patient and the doctor, which is very powerful, but also to other existing ecosystems or planned ecosystems, be it non-telehealth network payments or be it telehealth network payments, doesn't really matter. So we will fully anticipate and expect and focus on that interaction between us and existing physical and telehealth networks. We are running out of time, so let me go through a few simple questions because I'm being told we are well over our time limit. So let me grab one or two more questions and then we'll wrap up. Our company is going to buy Solve token from regular exchanges. So in the context of Global Telehealth Exchange, the patients can buy Solve tokens right in the Care wallet. There is no need for them to go on the exchange. And we have come up with an incredibly sophisticated model where the patient's ability to make an appointment is a similar experience as they would do to buy goods and services on Amazon. So we are not looking for them to open any exchange account. We're not expecting the patient to open any kind of crypto manual. They really don't need to do any of that. It's very, very simple. It's something that my mom should be able to use, and she does use it. On the other hand, the physician side, the physicians can redeem tokens by initiating a redemption request within their web wallet. It does connect behind the scenes transparently to the appropriate exchange to sell those tokens in the market. But as I mentioned earlier, there's a hedging mechanism already in place that allows for the physician to have a guaranteed redemption price, and that the entire backend is handled by the Solve token exchange, which we will talk about in another session. So the answer in short is neither the doctor nor the patient needs to open an account on the exchange. And then let's grab the last question. One of the bullet points in the GTHE website states, report symptoms online and securely store medical data. Would be good to understand what data is being referred to and where it will be stored. I think we covered part of it. But when we speak about reporting symptoms online, what we are talking about is the ability for a patient to use a care card in a private exchange with their paired physician node with whom they have either made an appointment or plan to make an appointment, and do so in a manner that becomes part of the physician's cabinet where they know that this patient has reported either pre-visit or post-visit symptoms that they need to be aware of. Let's say that I have been consulted. I have consulted a physician online through Global Telehealth Exchange. I have received a prescription, and following the prescription intake, I'm experiencing certain symptoms, either voluntarily or in response to a "How are you feeling today" card. I can easily respond to my symptom, provide my symptoms to the physician, and they become part of the care record. which also allows the physician to, or the GTHE ID or the physician to take action and advise me what needs to be done. So that's the kind of concept that we are working with. And the notion here is that over time, Global Telehealth ID can be expanded to provide physicians standard response to standard scenarios, so the physician can foresee and provide guidance to me, my care protocol, through the GTHE ID without having to be physically engaged all the time. But that's more to come on that front. And I think with that, there are many, many more questions, and I think we could go on for several hours, but let me do a wrap up. So the wrap up here is the following. The revenue and the utilization model of Global Telehealth Exchange has expanded dramatically. We are looking at a revenue model which is not just a cost per consultation, which varies between $10 and $100 for a office visit being replaced through a telehealth session, but rather a full care episode payment model, which means a single episode can generate tens of thousands of dollars of revenue for the same patient-doctor interaction. We are looking at bringing in different types of care models, specialty care, concierge care, in addition to telecare, which is a much more expanded use case. We are seeing tremendous feedback from physician community around the world. Many of them are seeing this as finally a freedom from the current bureaucracy that they have to live inside. And we've heard this word used again and again. This frees me to practice medicine in the way I've always wanted to practice medicine, and removes all the friction out of my life, which is a fantastic feedback we are getting. And we're getting this feedback from all types of specialty care providers, along with the primary care providers. And third, and last but not the least, we see that our Global Telehealth ID is an integration point for other telehealth solution providers. Our credentialing system is a value add proposition for medical and research and educational and administrative entities. And we are going to make sure that in the first launch, all of that capability is adequately tested so that we can have a very broad adoption and utilization model for Solve.Care, both for appointments made within GTHE and for networks that exist outside of GTHE. And we are resetting our launch date for Q4 to accommodate this significantly expanded scope. And we'll keep you up to date as we go through the journey of testing and certifying the GTHE with our physician community and our ambassador program. I encourage all of you to come back with questions, answers, feedback, use cases, ways that you think GTHE can expand its value proposition. The team, I know, will continue to work very hard and is working very hard to launch a very ambitious solution in the market, of which there is no parallel ever. This is a brand new market we are creating with GTHE, and we're doing so in one of the most complex industries of all, healthcare. So I appreciate your continued support. I am hopeful that you will find the approach and the strategy that we have put forth as an incredibly compelling one, but we know there is always opportunity to improve it. So we welcome your feedback and thank you for your continued support. And have a great day, everyone, and stay safe.